Hello, everyone. We will begin the webinar in about 30 seconds. Hello, my name is Arya Javidan, and I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC webinar series. Today's session is on Can You Hear Me? Equitable Access to Telehealth for Deaf, Hard of Hearing, and Deafblind Patients. In today's webinar, we have several subject matter experts who have hearing loss themselves. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just to provide a little background on the consortium located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Just a few tips before we get started. Your audio has been muted for today's webinar. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please only use the chat feature for communication issues with technology or communication access issues. Please note that closed captioning is available, and that is located at the bottom of your screen. Today's webinar is also being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel and the NCTRC website at telehealthresourcecenter.org. With that, I will pass it over to Kathy Wibberley, Director of the Mid-Atlantic Telehealth Resource Center.
Welcome, and thank you for joining us. As Arya mentioned, I'm Kathy Wibberley, Director of the Mid-Atlantic Telehealth Resource Center. And I just want to cue you on a couple things related to communications housekeeping. So we have American Sign Language interpreters that will be on screen throughout the webinar and will be viewable on the recording. The only time that the ASL interpreters will not be available is during the showing of videos, which we will have quite a few today. CART, or Communications Access Real-Time Translation Captioning, is available by clicking on the CC icon at the bottom of your screen. But for the benefit of those who would prefer their CART or captioning in a separate window, I'm going to put that link in the chat box right now. Oh, I see it's already there. So great. The National Consortium of Telehealth Resource Centers and Mid-Atlantic Telehealth Resource Center have been partnering with the North Carolina Division of Services for the Deaf and Hard of Hearing on building provider capacity to better serve populations with hearing loss. We have invited Director Jan Withers to open our training by sharing a few key thoughts in this regard. And she is going to be coming on by video.
Hello, I'm Jan Withers, Director of the Division of Services for the Deaf and Hard of Hearing within the North Carolina Department of Health and Human Services. As you're viewing this video, I'm actually on vacation, but because the topic of healthcare accessibility is so important to me, I am grateful for the opportunity to speak to you via this pre-recorded video. In my work, I focus on fostering systems change to ensure communication equity for deaf, hard of hearing, and deafblind patients in healthcare. As someone born deaf, this is also personal. In the U.S., there are 48 million people with hearing loss. We experience everyday barriers to effective communication, too often at a great cost to our health. The National Institutes of Health recently recognized people with disabilities as a historically marginalized population that also experience health disparities. As a result of our experience fighting so many times for communication access, we find it hard to trust the system, and we must be hyper-vigilant. Having to advocate for our communication access can be nerve-wracking. Whenever we seek health care, we must be on our toes and go the extra mile to make sure appropriate communication accommodations are provided. As a result, many of us experience advocacy exhaustion. It's bad enough trying to get communication accommodations when you're healthy. Imagine what it's like when you're exhausted and weak due to a major illness. Our goal is not to have to advocate for our communication access and to have complete confidence that the healthcare system is consistently functioning with our needs in mind, resulting in us being able to communicate effectively with our providers. In other words, we want our experience to be equivalent to the experience of everyone else when seeking and receiving healthcare. Even though the goal of effective communication is simple, there are several common barriers that make achieving the goal a challenge. First, poor connectivity. Often the issue is at the provider's end. The video of the interpreter could be choppy. This is like a phone call where the audio breaks frequently. Many telehealth platforms are not designed with accessibility in mind, or at least with a full understanding of what it takes to make the platform fully accessible. Even if the platform is well designed for accessibility, the provider fails to allow sufficient time to ensure the accessibility features are activated and also working appropriately. Therefore, it's important to schedule extra time for a patient with a disability, and providers are legally prohibited from charging for that extra time. The provider and/or the patient lack the digital skills to effectively manage the accessibility features. The sign language interpreter may not be qualified to interpret a medical discussion. The interpreter may lack knowledge of the specialized vocabulary and subject matter to be able to interpret effectively. Providers or people who develop telehealth platforms fail to understand that people with hearing loss use a wide variety of communication methods. For example, the vast majority of people with hearing loss do not know sign language and therefore need captioning services. Finally, many providers fail to understand that the mere provision of an accommodation does not ensure compliance with federal accessibility laws. The accommodation must result in effective communication. That is clearly stated in the Americans with Disabilities Act. To make telehealth fully accessible, it helps to start with the following basic features. First, make sure there is a third video frame to include the sign language interpreter, and that it's big enough to allow the patient to easily see the interpreter. Second, make sure there is a way to show the captions of the conversation and that it can be easily viewed by the patient. Third, Ideally, the patient should have the ability to manipulate the size and the placement of the video frame, of the interpreter, or the frame showing the captions. Finally, never assume a telehealth platform is fully accessible. It's important to invite people with lived experience to test it before purchasing. I also encourage healthcare facilities to adopt policies and procedures and to provide periodic training for providers to ensure that communication equity can be assured at every encounter. Thank you.
To get us rolling with the content we'd like to share today, I'd like to invite Darian Gamble and Tony Davis to turn on their cameras so you can see them. Darian is director for Deaf Inc. in the greater Boston area of Massachusetts, where she oversees 5 regional offices. And Tony Davis is the Accessibility Resources Manager for the North Carolina Division of Services for the Deaf and Hard of Hearing in the North Carolina Department of Health and Human Services. Darian will share information about the different populations with hearing loss and the typical accommodations that each uses for telehealth appointments. Following Darian, Tony will show us different telehealth scenarios to show the patient experience when accommodations are and are not provided. So Darian, the stage is now yours.
Thank you, Kathy. Hello, everyone. I am Darian Gramble, and thank you again so much for joining today's webinar. Anytime you learn something new, whether it be culture, diversity, you always learn a different type of diversity. So today, our focus is going to be what does equitable access look like for deaf, hard of hearing, and deafblind patients? So what does it look like for those 3 populations? First of all, I myself am a deaf person, so I can easily relate to this topic and I clearly understand what it's like to be in this world. As a deaf person, that could be someone who was born deaf, who can't hear anything at all. Perhaps it was hereditary. Perhaps it happened later due to an illness in life. There's various reasons why a person could be deaf. Secondly, deaf people use American Sign Language, or ASL. It's visual and it contains gestures as well. Next, you have the hard of hearing population. That's a term you might often hear is people say, oh, I'm hard of hearing, or I can hear some, or I have difficulty. And that would be the people in this hard of hearing population. They have some residual hearing and oftentimes can speak with spoken English. And there are some deaf people who can speak as well, based on their education and their training. But for the most part, of people that identify in the deaf category do use American Sign Language. It's also sometimes very easy to misunderstand as a hard of hearing person. So it's very important whenever you're interacting with patients to first make sure you're on the same page when it comes to communication and that it's clear between the both of you. Thirdly is a population that involves deaf-blind people. A deaf-blind person has a hearing and visual loss, so a dual sensory loss. You have those that can't see anything. You have some that can see some and has some residual vision, although it may be limited. But everyone in this population has a wide variety of what their hearing loss and vision loss looks like. Just like with language, one size doesn't fit all. So when a person identifies as deaf-blind, again, it really just depends on how much residual vision and hearing they have in both of those categories. A deaf-blind person may also be able to access large print visually, or may be able to access things with the correct lighting. So that's a little bit about of the 3 different populations that we have in our population. So now let's take a look at what that might look like. So when someone comes into your hospital or your healthcare facility, it's very important to understand the different types of accommodations that's there and available for any of those people in those populations I just spoke of. For a deaf person, the majority will request an American Sign Language interpreter. Sometimes they might request a deaf interpreter, and you might think, well, what does that mean? It means a deaf person with lived experience who understands their culture and language, who is an interpreter, and they most of the time work with a hearing interpreter to facilitate that communication. The reason why a deaf interpreter might need to be brought in is a patient might be from another country. They might be more using more visual gestures, and they might have a different language. So those are some things to think about and just to be aware of that might be needed in your facility when it comes to interpreting. Others use CART or captioning services such as we're using here today. It's real-time captioning, and this can be used also. That is another form of an accommodation. So now moving on to the hard of hearing population, some accommodations might be assistive listening devices or ALDs. A lot of hard of hearing prefer to have those because they still do have that residual hearing, and they just need some amplified sound to help with the communication. Some people in this population also use CART or captioning services as well as sign language interpreters. So that's a bit about the hard of hearing population. Now, with our third deafblind population, what you might not be familiar with is what's called tactile American Sign Language. That means the deafblind person will have to physically feel with their hands the interpretation or ASL that's happening. That's tactile American Sign Language. Others might prefer a close vision interpreter, where the interpreter will need to stand very close to the patient so they can see the sign language interpretation happening. Again, a deaf interpreter might be a huge benefit to a patient that is also deafblind. Some states actually provide SSPs, which is a sighted support provider, or what's also called a co-navigator. Each state has different wording on what this person's title is. However, the function is the same, and where the person will act as a human guide for the patient to access services. And that's another way of facilitating communication as well. Again, CART or captioning services are utilized for this population as well as the assistive listening devices that I just mentioned. Braille could also be another form of accommodation. You would be surprised that not many deafblind people know Braille because they rather use tactile American Sign Language. So just be careful and don't assume that all people use Braille or you know what accommodation they need. When it comes to the SSP and the co-navigator, that is something that's gaining popularity in our profession and amongst our community. It is a wonderful tool for people who identify as deafblind, for them to maintain their independence and also to ensure they have access. So all of this in a nutshell is talking about what does equitable communication look like. And so just a little bit of a lesson on what's more to come. So thank you so much.
Thank you so much, Darian. It was really great to have that overview on the different populations with hearing loss and also the accommodations that they use. It's important for all of you to understand that the accommodations that Darian just talked about, the communication accommodations, are available for telehealth appointments, not just in person. So they need to be available to both somebody who wants to come into the office or into the hospital, and then also those who wanted to be treated by telehealth or telemedicine. When we planned this webinar, we knew that we wanted you to see firsthand the experiences of deaf, hard of hearing, and deafblind from the viewpoint of the patient perspective using telehealth. So what better way than to show video vignettes from the perspective of the patient with hearing loss? We are now going to show you 9 very short videos, which will give you that perspective. I will come on the screen before each of the videos and explain what you will see, and then you'll see it. And when we are all done with all of the videos, we will discuss the outcomes more in depth. Thank you. So Kathy, if you could please pull up video demonstration number 1. This is an appointment where a deaf patient has requested an American Sign Language interpreter, but the interpreter is not provided.
Good afternoon, Mrs. Johnson. It's good to see you today. I'm Dr. Wright. I'm sorry that you're not feeling well, but hopefully we'll get you back up and running in no time. I don't understand what you're saying. I'm sorry, I don't know how this happened. No interpreter. I'm sorry, there's no interpreter. Do you want to type back and forth? Type.
You recognized how effective that appointment was. So we will now show you demonstration video number 2. At this appointment, it's the same deaf patient that has requested the American Sign Language interpreter. However, this time, the American Sign Language interpreter is provided.
Good afternoon, Mrs. Johnson. I'm Dr. Wright. It's good to see you today. I see that we have an American Sign Language interpreter with us for this appointment. Please let me know if there's any problems with the communication and we'll work to get those fixed, okay?
Yes, good to see you. Thank you.
Sorry to hear that you're not feeling well today. Hopefully we'll get you back up and running like your normal self in no time at all. Okay.
Yes.
Before we get started, can you just verify your full name and date of birth for me, please?
Sure. My name is Shalene Johnson. Birthday is June 24th, 1971.
Great, thank you. And it looks like you reported you've been having headaches, body aches, and congestion for 3 days now. Is that right?
Yes, you're correct. Yeah, I've been having a major headache, body aches. I can't seem to breathe well. Also, my nose has been really clogged up and it's been hurting.
Okay.
I notice sometimes when I wake up in the middle of the night that my bed is wet, like my pillow, I think from perspiration, and really bad.
I'm sure you could see the difference there with that appointment. The next video will be demonstration video number 3. And we're going to have an appointment where a hard of hearing patient is there. They've requested communication access, real-time translation, CART captioning, but did not receive the accommodation. We're going to join this appointment after it's already started and the questions have already started to be asked from the provider to the patient.
What's the street address of your house?
I have maple and pine trees on my street.
Okay. I'm going to name 3 objects, and I want you to repeat them back to me and then remember them because I'm going to ask again in a couple of minutes. Ball, car, man.
I don't know what you said.
Okay. I'm going to name 3 objects, and then I want you to say them back to me and remember them because I'm going to ask again in a few minutes. Ball, car, man.
I don't know what you said.
Next, we are going to look at demonstration video number 4. This is the same hard of hearing patient, but this time with the current captioning accommodation that is provided. You'll see a difference.
Good morning, Mrs. Baker. It's good to see you today. I'm Dr. Wright. I see that you met the nurse and got checked in. I'm going to do an exam where I ask some questions to see how your memory is doing and if you're forgetting certain things. Do you have any questions before we get started?
No, I don't think so.
Okay, great. What year is this?
It's 2024.
What season is it?
It is winter.
And what country are we in?
We are in the United States of America.
You saw how effective that was with an accommodation captioning. We will now show a deaf-blind patient with their appointment. This time, an accommodation has been provided. However, it's the wrong accommodation. The patient has requested a tactile sign language interpreter, and instead, an American Sign Language interpreter is provided.
Good afternoon, Mrs. Avery. It's good to see you today. I'm Dr. Wright. I see that you have an American Sign Language interpreter today. How's the interpreter working for you?
I need a tactile interpreter.
Miss Avery, are you understanding what I'm saying?
I need a tactile sign language interpreter.
Is she under? Can you understand me?
I need a tactile sign language interpreter. And doctor, this is the interpreter. It seems as if Miss Avery would need a in-person tactile American Sign Language interpreter. She can't access me visually.
Oh. Okay. Thank you.
So you saw there, it's actually possible to provide an accommodation, but it's not provided in the correct way. Next, we'll show you demonstration video number 6. This is the same patient. However, this time she has the correct accommodation, a tactile sign language interpreter.
Good afternoon, Mrs. Avery. It's good to see you today. I'm Dr. Wright. I see that you have a sign language interpreter today. How's the interpreter working for you?
Yes, I have a tactile ASL interpreter. I'm good, thanks.
Great to hear. Thank you. If there are any problems with communication, just let me know.
Okay, I will.
Great. Today, we're going to be talking about your upcoming foot surgery that'll be happening in March. I'm going to be talking about what we'll do, ask some questions, and then we'll go through the consenting process.
Yes, I can't wait to get this over with. I'm ready.
Fantastic.
So you saw the difference there. The next video we're going to show you is video number 7. And in this situation, a deaf patient is calling a provider's office through video relay services. That's an American Sign Language interpreter through video relay conferencing. And they're going to call and they're going to request an American Sign Language interpreter from the appointment scheduler saying, I want an American Sign Language interpreter for the appointment.
Good morning, All Patients Healthcare. How may I help you?
Hello, this is VRS Interpreter 2025. I have a person using sign language on the line. I'll connect your call now.
Okay.
Good morning. I'm calling to make a telehealth appointment with Dr. Lynn, Lynn.
Oh, sure. No problem at all. We have appointments today at 4 p.m. or tomorrow at 10 a.m. or 1:30 p.m. available.
I'll do 10 a.m. tomorrow morning.
Okay, sounds great. Can I get your name and date of birth?
My name is Donald Coleman, and my birthday is 10/04/1980.
Okay.
Oh, by the way, I need to make a request for a ASL interpreter for my appointment as well because I am deaf.
Oh, we'll need you to come into the office to be seen. We have appointments next Monday or Tuesday.
No, I really want to have a telehealth appointment.
Oh, we don't schedule sign language interpreters for telehealth appointments, only in-office appointments.
We are not going to show you video number 8. Basically, that video was the same, except the scheduler said, we'll go ahead and set up the interpreter for the telehealth appointment. That'll be just fine. So you see the difference. The next video that we're going to show you is going to demonstrate, or it's actually going to allow you to try your ability to read facial expressions and do a little bit of lip reading. Let's see how successful you are at that. And then lastly, we're going to give you the opportunity to try to do the same thing. Understand the telehealth provider. Again, you have hearing loss, so you can't hear them well, just like in the previous video. But you're also going to try to see them through a little bit of background lighting. Let's see how that goes. So hopefully today you had a chance through watching those different videos, a little bit of what it's like to be a patient without an accommodation that has hearing loss. So in an in-person presentation, what I would do is I would ask you how watching those videos impacted you, how it made you feel. And so today, what I'm hoping is that you take a few minutes, either during this presentation or afterwards or on your way home when you're driving, to think about how it made you feel for the patient not having the accommodation, to be able to walk in their shoes a little bit. Let's talk a little bit about what we saw with the different videos. Let's start with video 1 and 2. And the deaf patient who had no interpreter when they requested one. Obviously, there was no communication that was happening between the two. The patient typed in the chat, "Hey, I don't have an American Sign Language interpreter. Where are they?" And the provider typed back in the chat and said, "Hey, do you want to use chat to type back and forth?" It's really important to understand that American Sign Language is not English, and typing back and forth, like just like writing back and forth in the office, is not oftentimes effective, especially for somebody who uses American Sign Language as their primary language. You might have a few people who want you to write back and forth or who want you to type back and forth, but that's not going to be common. And so to ask them to do that is not equitable. It's not equitable communication. And it's probably not going to be effective in that situation. You could see in the second video that when the person who was deaf had an American Sign Language interpreter, they were able to effectively communicate, even though they didn't feel well. Communication is a two-way street. It's important for the provider to understand the patient and to be able to understand the symptoms that they're experiencing and all that, something that can be totally lost in chatting back and forth or totally lost when writing back and forth. As it is for the patient to understand what the provider is saying back as far as treatment goes and as far as what they're experiencing, it being normal and so forth. In the third vignette, we saw that a hard of hearing person didn't have captioning, and they were very confused, or actually they looked very confused. They were trying to understand what was being said, but they couldn't, simply because they had hearing loss and they needed captioning. This could really impact the diagnosis. It could really impact the treatment of a person, especially when this person was taking a mini mental status exam like they were in this video. It really doesn't matter what type of appointment it was. It would greatly impact them if they couldn't understand what was happening. In the next video, you saw that the person had captioning throughout the appointment, and it was extremely effective. Now, it sometimes slows down the appointment a little bit, and that's okay. Director Withers talked about that earlier. She said people need more time for their appointments. That's okay. It's not a problem to schedule a little bit more extra time when you meet with the patient. That's really important to ensure that they have effective communication, whether that's telehealth or that's in person. With video number 5, with the deaf-blind patient, they needed an American Sign Language, a tactile sign language interpreter, but instead they were provided an American Sign Language interpreter. This could easily happen. We could see a provider providing the wrong type of accommodation. It can happen. That's why you have subject matter experts in your state to help you. Just like I am in our state of North Carolina, and I'm happy to help those providers in North Carolina to understand better how to serve deaf, hard of hearing, and deafblind patients. There's other subject matter experts just like myself in other states that you can contact with the state or other entities, private entities, nonprofits that can help you through that. We'll also talk a little bit about some guidance that we've developed that everyone can use that we'll share with you later. You saw the deaf-blind patient shaking her head throughout that first appointment because she didn't understand anything that was going on. And honestly, that appointment would have never happened. The deaf-blind person would not have been on screen. And the reason why is because the tactile interpreters would have never shown up at her house or wherever that she was meeting them. And so the provider would have just assumed that it was a missed appointment by the patient. And so again, it's critical that we provide the right accommodation to somebody that asks for a specific accommodation, because providing the wrong accommodation to somebody is not going to provide communication access. Number 7, the video 7, when the deaf patient called in and tried to set up a telehealth appointment, we see this often. This is common. It's very common for providers to offer telehealth appointments to people with no hearing loss, but it's often that providers won't offer that same telehealth appointment to somebody who's deaf, hard of hearing, or deaf blind. And number 9, we saw a provider with a face mask that covered most of their face. Can you imagine trying to understand facial expressions through a face mask like that? Very, very difficult. Some people do rely on lip reading. Some hard of hearing people do to a degree, even though only 30% of what's said on the lip is actually understandable through lip reading. Number 10, you saw significant backlighting. It would be really difficult to understand what somebody said with backlighting that's so strong. So really, it's important that when you set up a telehealth appointment, that your background is good, that it's not too strong, and that you're easily visible, that your face is visible when you meet with people. We totally understand when we look back at the face mask that you need to be safe. But think about how you can set up an environment, especially working with somebody with hearing loss, how you can set up an environment that allows them better communication access. That might be moving to a private room or doing something like that. Give me 1 second, please. Okay. Kathy Wibberley asked me to share a few telehealth experiences that people have experienced and reported to us. So I'll share a few of these that were shared with us through a survey. A deaf patient called a provider's office and asked for instructions on how to use telehealth. A nurse talking to the patient changed her tone suddenly and said, "No, okay, we will call you on the phone, not through telehealth. No telehealth for you," unquote. Another quote, I have never experienced telehealth appointment with my doctors. They never offered it to me. However, they offered it to my husband who is hearing. Another quote, my doctor's office in a small town in North Carolina where I live provides telehealth through Zoom. However, when it came to my appointment, they were baffled on how to communicate. Another quote, I have had one telehealth appointment and it did not go well. It was a major healthcare provider, but the platform was not stable and the provider's picture and audio went in and out and the communication was not good. Another quote, as a person who's deafblind, my biggest struggle is trying to request accommodation, such as an ASL interpreter. I wish they would have a communication access drop-down feature on the portal where there was a request form listing various accommodations that I can fill out. And the last minute or so, I want to share a resource with you, if that's okay. If you could pull up my PowerPoint, Ria. So this is a telehealth guidance webpage that our division in North Carolina has developed, the Division of Services for the Deaf and Hard of Hearing. It's the only telehealth guidance for deaf, hard of hearing, deafblind patients and their providers that we know about. There's 28 different resources on here. Next slide, please. By the way, you can, that PowerPoint will be passed out. There's only 4 slides, but there's a clickable link on there. And if you click on that link, it'll take you directly to the website and you can navigate the website there. The one really important material that I suggest you check out is for healthcare providers, because the majority of you are healthcare providers. And that has a purple icon on the website. And there's a guidance document there called Guidance for Telehealth Providers. There's a drop-down menu It's 11 pages long. Don't let that scare you. There's a drop-down menu on that guidance. It's clickable. You click on whatever you want to read, and it'll take you directly to the guidance that you want to read about. So you could do maybe half a page a day and just learn a whole bunch of what you need to know on how to better serve deaf, hard of hearing, and deafblind patients. It's excellent. It's one of a kind. Next slide, please. Another guidance document on this telehealth website is the telehealth glossary. Now, this glossary is excellent because it'll give you knowledge, actually definitions of all that you need to know. So for instance, it'll give you the definitions of the different populations that Darian talked about earlier. It'll also tell you the different types of accommodations that are available for patients with hearing loss. And then lastly, it'll talk about different disability acts and the laws that we need to follow as providers, including, for instance, American with Disabilities Act. So it'll give you all of that really pertinent information that you need to know. And then lastly, if you'll go to the next slide, there's a communication accommodation request letter, which you're welcome to use and share with your patients. This letter would really help your patients to be able to request the type of accommodation that they need. You could also use this letter as a model for the different ways you can provide accommodations to the populations you serve, those with hearing loss, of course. So for instance, it has ASL interpreter, CART, ALDs, close vision, you name it. So it's a checkable, fillable accommodation request letter. I'll go ahead and turn the time over to Kathy and Dr. Nutt.
Thank you so much, Tony. These resources are amazing. We have shared them far and wide and definitely encourage you to view them. So our third and final presenter is Dr. Robert Nutt. Dr. Nutt received his medical degree from Dartmouth and completed his pediatric residency and clinical fellowships in both academic general peds and developmental and behavioral peds at the University of Rochester Medical Center. He has held multiple faculty appointments and has served on numerous task forces and advisory committees and is a true champion for accessibility. He'll be sharing a little bit about provider bias from the provider side of things and how it pertains to providing communication accommodations, and that, to really show that it really is an issue. So Dr. Nutt, handing it over to you.
Yeah, thank you, Kathy. I think the first thing that I'd like to point out to everybody as humans is that we have a tendency to gravitate towards what we feel comfortable with, what we know, and we have an aversion to those things that we do not know. And even though we are in the medical field with the area of telemedicine and telehealth, we look for things that we don't know, and we enjoy puzzles and challenges. But even so, we are prone to gravitating toward those things that we are familiar with, comfortable with. And for many of us, that may be working with typical patients who are not deaf or hard of hearing, deafblind, who do not have other disabilities, who do not need accommodation for communication access that we're talking about today. So what I'm going to talk about, I hope that you keep that in mind, is that just like the tendency for some providers to gravitate towards certain diagnoses or use certain prescriptions or refer to certain specialists that may cause a rush to judgment. And we learn that very early in our medical careers, and we do everything we can to avoid that rush to judgment or that tendency to walk in a path that has been well trodden, and rather keep our mind open to those things that are not the usual cases that we see. If we don't resist that, then we end up missing those cases. And so for the good of our patient care and for better outcomes for our patients, I hope that you will use this as an opportunity to be reminded to pursue those issues and those encounters that you're not necessarily comfortable with. And that said, there has been a publication that came from a group in Northwestern UMass and Harvard Medical School in October of 2022. And that study looked at the patients as well as 22 community clinics and surveyed the physicians about the view on patients with disabilities and caring for those individuals. And findings were interesting and got the attention of a lot of us who are involved in disabilities and access to care. So the physicians reported in the study feeling overwhelmed by demands of practicing medicine in general and the requirements of the ADA. And so some of you are feeling that already. I can see that in some of the questions that are coming up that I hope we can address in the QA. It is really difficult to accommodate some of the things in the ADA as a separate practice or as a system. And through the telehealth interface, it's something that we certainly need to be thinking about. As you saw from the video, some of those additional of time, and we heard in the first presenter, Jan Withers, stated that there are limitations in what we can bill for the extra time that is required to accommodate patients who do need communication accommodations. The study also found that physicians reported being inadequately reimbursed for the accommodation, and hopefully some of the resources that Tony Davis provided and some of the resources in your states will help you look for ways that these accommodations can be reimbursed. The physicians also reported attempts to discharge people with disabilities from their practices because of these forces of time and of financial constraints. Obviously, that is a dilemma that we have that we're hoping to get some attention to, and that this publication, which was also shared in some of the more widely distributed periodicals, that is an issue, questions medical ethics and medical practice, but it does highlight the reality of pressures of practicing medicine under the constraint of the ADA and financial reimbursement. The requirements for accommodating and increasing healthcare for individuals with disabilities that the physician reported wanted the increase in accessibility of space for physical disabilities, the availability of proper equipment, and a need for a place to put that equipment, the cost of that equipment, etc., and improving the education of clinicians about the care of people with disabilities. That's one of the things that we can do to address some of the needs and constraints that the physician reported in the study. We also need to remove structural barriers and logistical barriers that I hope are coming to light through the presentations in this webinar. But the reality is that physician bias towards individuals and patients with disabilities and the general reluctance to care for people with disabilities plays a huge role in perpetuating the healthcare disparities that these patients experience. So what is bias? In the limit of time, we can give a whole presentation on this, but I'll go through it quickly. There's sort of two types of bias that I want to highlight. Okay, so there's the known conscious bias that we have, that we're aware of, that we may use on a day-to-day basis. So this is illicit bias or conscious bias. And that examples of this may be overt racism and racist comments this is an example of explicit or conscious bias that individual's views of others. in terms of disabilities, there may be what we call ableism. Okay, there's a judgment based on previous experience, based on what we're comfortable with, that we assume and apply to individuals with disabilities. And in the case of individuals who are deaf or hard of hearing or deafblind, the term that we use is autism. That means we focus on the ear, we focus on the ability or inability to hear, and lose the ingenuity of all the other abilities that the individual does have. So, implicit bias is unconscious bias. Okay, that's one of the things that we really need to be aware of, and it pushes us into some of those areas of being uncomfortable. Yeah. An example of this is that when you hear the word, when you hear somebody refer to a kindergarten teacher, that teacher, many individuals and most individuals will picture a female teacher. That is implicit bias, the cultural norms and generalization and tendencies, and that unintentional application of some of those prejudicial views of a group or an individual may be applied. And we saw some of this in some of the videos of the incorrect accommodation or certain awkward moments where somebody assumes something that is not the case. So I hope that you keep these types of bias in mind as I make comments about telehealth. Okay. So telehealth encounters have raised concern for constraints of traditional clinical experiences. Those of us who are engaged with patients remotely for telehealth visits know that every platform that we use has inherent nuances. This is issues with connectivity, quality of video, dropped calls, distractions in terms of kids or pets running into the show. Or as Tony Davis pointed out, some of the lighting or even face masks can interfere with effective communication during telehealth encounters. Yeah. And then as we have traveled into along the learning curve and technology has improved the quality and efficiency of remote encounter experience, we now realize the capabilities of integrating telehealth visits in our clinical workflow. I certainly have experienced this in my practice, having multiple telehealth visits during the day. They can be very effective in terms of occurring between rooming patients, between waiting for a late patient. You can see sick visits and so forth. So there's definitely a logistical advantage to telehealth, as well as an application to improving care and not requiring a patient to come into the office. So I want to emphasize that communication is key for all encounters, but becomes even more so for telehealth encounters, in the same way that breathing through your mouth is easy and breathing through a straw is much harder. That analogy is often used for the constraint of communication. And when we talk about deaf and hard of hearing and deafblind patient, that straw gets even more narrow, and that is something that we have to remember. Okay, so when we begin, we have to make sure that the patient has the ability to communicate the history, and we have to listen to that history. That's where medicine and our encounters begin, and that is the most important part of every encounter. Okay. One thing I do want to emphasize is where can this happen? Many of you may feel like this is the responsibility of the deaf patient. That it's important for them to make sure that they explain to you and your practice or your system what they need. It's important to realize that it's not only on the deaf individual to explain this, what their needs are, but it's important for us to reach out and identify what their needs are. The most effective place to do this, maybe in your social history when you meet the patient, is to begin to understand what their needs are. But even before that, preparation is key. It may occur long before the clinical encounter in order to ensure that that initial visit has the appropriate accommodation. And this may be the intake, the scheduling, or somebody identified in your practice to make sure that the individual communication met their need, that the communication needs are met when you as the provider start your visit with that individual.
Dr. Nutt, thank you so much for this. We're kind of short on time, so I don't want to cut you off, but I do want to say, you know, we wanted to leave a little time for Q&A, but I think we're pretty much at the end right now. So all of our presenters have agreed to take the questions and create a document with the answers, but the guidance document that Tony shared also has many of the answers to the questions that are being asked as well. So with that said, I just want to say thank you to all of our presenters for the wonderful materials that you shared, and I will punt to Aria to wrap us up.
Thank you, Kathy. Just a reminder that our next webinar will be on March 21st from 11 a.m. to 12 p.m. Pacific. Registration information will be available on the NCTRC website once a topic is finalized. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar, as your feedback is very valuable to us. Thank you again to the Mid-Atlantic Telehealth Resource Center for hosting today's webinar, and to all of our speakers for sharing their expertise today. Have a great day, everyone.